Good morning, good afternoon, good evening. Section 3, welcome to the Week 6 Achilles tendon and plantar heel pain week in review. Hopefully everyone is doing well. Had another good week. Everybody was doing a great job of participating and really sharing a lot of insights. These discussions have not as much evidence as some of the stuff we've had in the past, and so it makes it harder, but it also opens it up for people to experiment with different things and see what works and what doesn't, and kind of open the discussion in a different venue. So we can review presentations. The Tehan presentation was really good for heel pain and plantar fasciitis. I just kind of captured a couple of things that I thought were really important. Plantar fasciitis, the lacking of dorsiflexion and great toe extension, I thought were kind of her hallmark take homes with that. First step in the morning is painful. These things are pretty common things that we see. Seen with a sudden increase in activity, not increase, but increase. Stretching and myofascial trigger points. I pointed that out because when our own JOSPT publication uses that as a reference, and that is what she points to as treatment approach, then we know we've kind of gone down the road of, well, we don't have a lot of evidence when that's what we're recommending. The Landorf study looked at orthotics being no different with custom versus regular inserts, and then shoe conditioning, 500 miles. That whole shoe debate, man, that some runners get really obsessed about this stuff, and while it certainly can, I certainly think after a while it can have an impact. As a person who's done marathons myself and triathlons myself, and I run all the time, the 500 thing I think can be kind of overblown. I don't find it to be all that, and granted I am an N of 1, but there's other research out there, or there's other examples, I should say, out there that would say the shoe industry wants you to buy more shoes, and runners become somewhat fanatical about their shoe wear. So I think it's important to have shoes that aren't falling apart, but I think sometimes you can go longer than 500 miles. Lord knows I have. So, Flynn's stuff is pretty in depth in regards to each of the different pathologies. I just point out that Danielle in her case study this week had a medial tibial stress syndrome, and it was an interesting case presentation. And if you're interested in all in that, I'd go check her stuff out. She had a nice presentation to read about. You just talked about various tendinopathies of the foot, and we know that tendinopathies all really respond well to, as we learned this week, eccentric training. So whether you get these or not, no matter where it's at, that's kind of where you go. I would give a shout out, speaking of Danielle, to the fellows. I thought they did a great job with their case presentations. These, in my opinion, these types of case examples that they're sharing with you are great, because I think this is of all the things that if you were to characterize the things that I don't enjoy treating, the foot is probably my least favorite of all. And it's not to say that I don't have success, but I just don't feel like it's dramatic success. And that's more indicative of the fact that it's a tendinopathy, and it takes, it's a more protracted recovery. It takes longer. It takes more persistence. It takes patients that are willing. And there's no bang in the clinic. That intercession change I've talked about really is often lacking. And so, I certainly treat my share of foot problems, but it's probably, of all the things, my least favorite thing to do. And so if there are other people who find it to be their least favorite thing to do and are maybe struggling with that, these fellows have presented some nice opportunities to delve into what they do as far as their clinical reasoning and their clinical judgment about these kinds of diagnoses, and perhaps you could all gain some understanding from. Next, the week in review in literature, that should be a presentation. I apologize. The Minkin presentation that he talked about manual therapy for foot and ankle disorders. Even he states right in the presentation that the comment about mesmerism. Yeah, we need more research in this stuff. We just don't have a lot. There is decent research for acute ankle sprains and manual therapy, and he speaks to that. The Mulligan technique has shown some promise for improving mobility. He ends up referencing the Cleveland study as some of the best available evidence for heel pain and manual therapy, and I would agree. I think ankle sprains and manual therapy are kind of the acute low back pain of the foot, if you will. We've got a nice clinical prediction rule for the acute low back pain. I think ankle sprains probably respond the same way if you can get a neurophysiologic input to dampen down pain and increase muscle activity, proprioceptive activity. it's a good thing. I always like the mulligan techniques. I always think are really good, and Bill Vincenzino out of Australia does a phenomenal job with his research, and he loves mulligan techniques. Maybe that's because Brian Mulligan, I think, is his good buddy, and sometimes the research doesn't bear out that the techniques really work, but sometimes they do, and he always does such bang up research. So whenever Vincenzino does an article, you always got to pay attention because he's a great researcher. So the articles regarding plantar fasciitis, the McPoyle clinical recommendations for plantar fasciitis, man, they need to update those. Obviously, when they're giving an A rating for orthotic interventions and a B rating for stretching, and then modalities are given a B rating, manual therapy gets an E rating. I mean, that's right up there with, basically believing what everything I say. We all know that we can't do that. The Cleveland, and that was before the Cleveland article came out, and granted things would change after the Cleveland article, but again, just more research needs to be done in this area before we can really stand strong. The Cleveland article was able to demonstrate superiority with manual therapy and exercise over exercise and modalities, and for some, they were already doing this, so this wasn't a really big deal. But for others, maybe putting the modalities aside at least initially and using more manual therapy was a kind of a new concept, and so hopefully we're changing some practice patterns. The article demonstrated both good short term and long term. I think for foot stuff, short term is huge. I really believe that if you get them going short term, that's the area to focus on, decreasing that pain initially. I think long term will just follow. All based on the premise that this was not an inflammatory condition. I think that, most people have all recognized now that this is a tendinopathy and this is not an inflammatory issue, unless there was some a significant increase in training or activity that would have caused a flare-up. We need more of these types of studies, and that's why it's important for you guys to stay tuned, for you to continue to monitor what's being pushed out, and not just at the end of this 8-week course say, I feel good about lower extremity, because maybe in a couple of months there'll be a good article that comes out that supports it or refutes it for that matter. But I think we'll end up seeing eccentric exercises are here to stay. Week in review, forgot the K. Articles for Achilles tendinopathy. Cook et al. Article on Achilles tendinopathy is rock solid. That's one of those hallmark articles. That's why it's masterclass, describing it as an overused tendinopathy, not inflammatory. Again, going back to that whole thing about moving away from these concepts of inflammation, these itises. Eccentric exercises become critical. AM pain is a hallmark for Achilles tendinopathy. I think that's one of the things that I don't think gets talked about enough, this AM pain, posterior ankle pain. We think about it much more commonly with plantar fasciitis or heel pain. The Ruse article, the progressive program was established due to the research by Alfredson. Hopefully everybody realizes that caused too much soreness despite them improving. So Alfredson really pushed eccentrics hard, and people got sore. So they got better, but they got sore. And so Ruse thought, well, maybe we could progressively load them, and maybe we could avoid some of that soreness. Again, emphasize the stepwise progression strengthens the support for eccentric strengthening. Standout post this week. So stuff I thought that was really good in the discussions, or things, maybe even things that I just thought needed to be talked about. In Alpha, Joe, Christina, Matt, nice discussion about progression regarding eccentric training and soreness that may occur while performing the exercises. So again, the discussion was really how hard do you push? How much do you allow them to tolerate pain? And again, that was the whole point of the Ruse article. I think if they're a go-getter and people aren't afraid, they can push harder. But there are certainly those people who are timid and afraid. I would have a great story if we had the time about a patient I saw just on Friday who showed up in a wheelchair because of heel pain. So they're definitely out there. But that's an important discussion that needs to be had. But we all need to be progressing them, and a little pain is not a big deal, or soreness, as the words I like to choose. In Bravo, Josh had some great insights about conservative versus surgical management of Achilles tendinopathy as well, or Achilles rupture, I guess in this case. Achilles tendon ruptures. There was some discussion about that. I posted an article about that. As well, the biomechanics of the intrinsic muscle strength that helps us maintain a stable and strong foot. There's a lot of biomechanics that go into the foot, and some of it can be really important. Obviously, there's a nervous system that's attached to those biomechanics that is equally important. But I think understanding the stability of the foot is important because it brings to the question, and this goes back to the barefoot running and perhaps always needing to have, motion control shoe to stabilize an overpronator, and all these things that we did, back in the 90s, even 80s, 90s, and even into the early 2000s, because we felt we really needed to control the foot. And then, lo and behold, that book came out, Born to Run, and they talked about that group in Mexico that just run. And they have incredible strength in the intrinsics of their foot. They're incredibly strong, and they're all used to it. And I thought, I kind of spoke to Josh, and I think maybe one other person, maybe it was Pierre, about that, and how, when Western medicine takes hold and starts to market things and convince people that this is what they need, lo and behold, this is what they think they need. And here we have this group in Mexico that, they don't have foot pain, they don't have these issues. And I drew the parallel with the Aboriginal tribes that don't have what we consider Western medicine's back pain in Australia. And there was a really good study by Lee that looked at that, and how when we get involved Western medicine with our fancy imaging and gadgetry and our thought processes, sometimes we can gum up the works. And so I did enjoy that banter. And Charlie, Sarah, Jamie, and Pierre and Jay all had this discussion issue related to cortisone injections. We see far too many of these. This is the first line of defense, and unfortunately, I think it's a padding of the pocket kind of an issue. The injection should really be reserved for people who show up in wheelchairs. To be quite honest, it shouldn't be this. It ends up being this passing thing. Well, this is what you have, and I could give you a cortisone injection if you'd like it, and that's just a few more bucks in my pocket. When in reality, knowing that this isn't going to last, and so I think that that's an important discussion to have. And then in Delta, Laura brings up the important fact that custom orthotics have not been proven to be better than over-the-counter. That was another thing, for a long time. When I came out of school, probably the first 5 years, it was, custom orthotics are the way. Find the subtalar neutral. Make sure that you get this midfoot, you get a posting done, and you know exactly how much inversion and eversion are occurring and how much calcaneal motion, and you're really restricting that. And in reality, that doesn't matter as long as you get some kind of stability, a little bit of stability for a short period of time. Danielle, Carmela, and Welton also discussed modalities. In the Cleveland study, we found modalities. In reality, the modality group didn't do that much worse than the manual therapy group, or that much. They weren't that much worse off, because they did improve. But I do think that we need to, if we're going to use modalities, we need to understand why we're doing that. What is the thought process? What is the reasoning, the judgment behind our use of these techniques? And if it doesn't match up with the pathophysiology of what we're treating, then we have to ask ourselves, why are we doing this? So moving on to week 7, ankle and foot disorders. More stuff on acute ankle sprains and so forth. There's 3 videos and 4 articles. We need to complete the group projects. Objective information will need to be done and posted by week, I believe it's beginning of week 8. So you guys wrap this stuff up, get your questions answered, and if you have any questions, feel free. We're going to be switching up the fellows and myself. So I'm going to be moving to Delta. Pierre's going to be going to, I think, Alpha, and Joe will be going to Bravo, and then both of us will be hitting, or Joe will be hitting some of Charlie, and I'll be helping as much as I can. If you have any questions, please let me know. You guys are doing a great job. I know this is we're all in the thick of it now, but we're getting to week 7. This one is hopefully not as intense, and we can finish up our group projects and have a good week. If there are any questions, feel free to contact me, and again, I hope you all are doing well. Take good care, and I'll see you in a week.